Hello, my name is Dr. Janet Gillett, and today we're going to be talking about care of the dying person. We're going to be looking at these under the framework of 5 priorities of care, which are nationally agreed guidelines which have been embedded within care plans for the dying for a number of years. They are embedded there in Taunton and Yeovil hospitals, St Margaret's Hospice, and in the community. These 5 priorities of care include, first of all, recognising that someone is dying, communication, and today we're going to look at what's different with COVID, who we need to communicate and how we communicate, and the language of communication about death and dying. Involving those who need to be involved, providing support where we can, and importantly planning, including prescribing for end of life with particular reference to specific COVID symptoms. So what are the challenges? We know that the death rate is between 1 and 4%, but this increases rapidly with increasing age and indeed can exceed 50% if there are significant comorbidities or frailty. Our aims are to rapidly assess and to manage symptoms of COVID and not forget underlying conditions. We need to ensure comfort for those who are dying and support for relatives, not forgetting our colleagues. If we are to do end-of-life care well, then what are the new communication challenges that we are presently facing? This is not a normal situation, and unwelcome change is being forced on us all, including those we're caring for. We need to somehow manage the uncertainty which becomes uncertainty in many cases. We're having telephone conversations with people we've never met, we don't know. We know that emotional responses may well be heightened, and we're all of us doing something that we're not used to doing. How we are feeling we will bring to the situation. It's particularly important when we're on the telephone that we're aware of our own sense of preparation, calm. If we're feeling under pressure or irritable, it's probably wise to take a short break first. These are difficult conversations at normal times, but there are added complexities now as emotions may be unpredictable and more volatile. So when we're communicating on the telephone, we need to be prepared before we have a conversation. We need to have as much information as possible, including that which the team may hold. Let's get them to share it with us. Introduce ourselves by name, not just by title. Say why we're calling. Ask if there's anyone else who would like to listen. Perhaps they could use speakerphone. Find out what the patient and the family understand about what is happening. It's good if we can use clear, unambiguous language. Avoid medical jargon such as TEP, DNR, subcut. People don't know what we're talking about. Sometimes if we talk about resuscitation, they don't understand and think it means actually the giving of antibiotics or putting up a drip, whereas in fact we know it means cardiac resuscitation. Be kind and honest. A phrase like "I'm sorry this sounds hard for you" means an awful lot to somebody who's struggling to come to terms with the reality of what is happening. People remember kindness for a long time. Listen for non-verbal cues. Sighing, crying, silence, hesitation, the pitch and the tempo of the voice. Are they listening? Do their responses to your questions absolutely seem appropriate? Or have they gone off on a tangent and they're trying to distract from the focus of the conversation? So our first priority of care, recognising dying. We know some of the indications of poor prognosis: increased breast rate, low SAT, signs of shock, tachycardia, pale, clammy, maybe an altered state, mental state with confusion or delirium. Somebody else may recognise dying and want to come and talk to us about it. Sometimes it's not just one person recognising it, but it may be team, And it may be over a period of a few days that it becomes clear that this person is now reaching the dying phase of their life. So how do we talk about death and dying? Maybe things are changing, but most certainly terms such as very sick, deteriorating condition, poorly or very poorly, not doing very well, may not get better, might not pull through. Try and avoid euphemisms. Be clear. Say what you mean. I'm sorry is a good start. And if you're talking to a relative, you might say they are sick. They're sick enough that they may die. It's kind, it's gentle, it's clear, and it will be appreciated. And in fact, if somebody is now dying, say, they or you are now dying. I'm sorry. We need to involve, support and plan. There are end-of-life care plans on Rio, and it's important that we document as much as possible about what we're doing with medications, those that we're stopping, making sure we are prescribing for end-of-life, and we'll look at this later, that we consider the physical care needs and have a conversation about nutrition and hydration. Families will tend not to raise this, but they believe that if they're not able to feed and give fluids to their loved ones, that they are actually letting them down, that we know that the natural process of dying is actually happening and people don't want to eat and drink, and that's okay. And we must also not forget spiritual care. So what are we going to say if somebody says to us, am I dying, doctor, or am I dying, nurse? What are you going to say? Most people, and we hear it quite often, will say they really cannot answer that, or even say, of course you're not, don't give up. And we often hear families talking like this, mustn't give up the fight. It's a good idea to try and understand why that person's asked you at this particular time. Are they seeking reassurance that they aren't going to die, or do they really believe they are dying and want to talk with someone about it? So I would tend to ask, I'd really like to know why you've asked me this now. What are you worried about? What makes you think you may be dying? And that will soon give you an idea of why they've asked you, and then you can answer appropriately. It's important also not just to answer their questions, but also find out what's important to them now by asking them. Where have they drawn strength in the past when things have been difficult? Where have they found hope? What's been important to them? They may have a belief, and if so, don't ignore it. You may not be able to get spiritual care support, but there may be someone in the family that you can talk with, or there may be a church connection. Get someone to contact them. Caring for patients at the end of their lives is about caring for the whole person and those who love them. And this is a legacy of our time, and we don't know what it's going to be. But if we can contribute in some positive feelings in times of distress, then let us. And by spending a little time exploring concerns and expectations now, we can show kindness, and this will be remembered afterwards. Let us look now at some of the medications we may be considering with a person who is actually approaching the end of their life. And on this page we're actually looking at some of the most common symptoms, and on the next we'll look at pain and excess respiratory tract secretions. So if somebody's breathless, either at rest or minimal exertion, and with COVID infection, this can be a predominant, very, very distressing symptom. If they're not taking an opioid in the past and they're still able to swallow, Oromorph would be the drug of choice, as it's very effective in reducing the distress caused by breathlessness and the sensation of breathlessness. If they're on a regular opioid, say they're on 60 milligrams twice daily of a morphine preparation, sustained release, that would be 120 milligrams daily, then divide by 10 and give them about 10 milligrams as a PRN dose for breathlessness. This is slightly less than the pain breakthrough medication dose, but it may be helpful with breathlessness. we need to titrate the morphine against their symptoms, and we are finding that with breathlessness people often need higher doses than they had in the past for breathlessness of COPD, when we'd use much lower doses and they'd be effective. If somebody's unable to swallow, then we can use morphine by injection. I would say here that the use of morphine or oxycodone, depending on if they're on a previous opioid, then if they're on oxycodone, then use oxycodone PRN. You may consider converting into a syringe driver, and I put this at the bottom. Would a syringe driver be helpful? And think about this if people are needing multiple doses. If somebody's very breathless and they're using an opioid to help control their breathlessness and it's effective, and then they become unable to swallow and are on an existing opioid, don't forget about this when you're thinking about converting and popping and using a syringe driver. Don't forget to include the background dose of opioid. With anxiety and agitation, if they're able to swallow, then benzodiazepine, lorazepam can be given sublingually, and this can be very effective. Or you can use levomepromazine. This is routinely used in our just-in-case boxes as an antiemetic, but here it can be an excellent anxiolytic as well. As you can see, the dose is slightly higher. That can be used orally. If they're unable to swallow, again we can see that we've got midazolam, benzodiazepine by injection, and we've also got levomepromazine that can be used. Once again, consider a syringe driver if repeat doses are required. Cough. We know that with COVID infection, cough is very distressing and it's very irritant, dry cough, and so simple Linctus might be helpful, mainly for its soothing effect, as would be lozenges or lemon and honey drinks, anything that will help lubricate. Oromorph once again can be used, or if they're on a dose of oxycodone and they've got Oxynom in the house, then use that. If they're on an opioid for background pain, then you might look at increasing the PRN dose by a third. Fever. If fever is distressing, then regular paracetamol if they're able to take by mouth. And if these patients are now, as we are anticipating, reaching the end of their life, it is acceptable to give a non-steroidal anti-inflammatory drug, and the easiest route to use would be a single daily dose of diclofenac as a suppository, 100 milligrams. The risk of causing harm through this is minimal. The benefit may be substantial in the dying patient. Let us ongoing management then of pain. If they've got pain and they've had no previous opioid, so once again we'd be using morphine in the form of Oromorph, or if they're not able to swallow, then we'd be using morphine by injection. If they're on a previous opioid, then we'd be using, for pain, a sixth of the 24-hour opioid dose PRN. Orally, if we need to give this opioid by injection, if it's either morphine or oxycodone, then we divide the dose by 2 for injection. Excessive respiratory tract secretions may or may not be a problem, but are just-in-case guidelines for end-of-life care. We're using hyoscine butyl bromide by injection, 20 milligrams 4 hourly. An alternative, if this is not available, we'd use the scopoderm patch, 1 milligram every 72 hours. The slight disadvantage with scopoderm is that it does cross the blood-brain barrier, so there is a bit of a risk that somebody may get more confused with this rather than hyoscine butyl bromide that does not. Once again, think, would a syringe driver be helpful in these circumstances? And please remember that if the patient has a fentanyl patch in place, continue the fentanyl patch, continue changing it at the prescribed intervals, and do not remove it. You can always add in additional opioid if required with a syringe driver. So in summary, titrate the morphine for breathlessness and cough according to effect. If somebody has got poor renal function, then you can still use these opioids, but reduce the dose and increase the dosing interval. If on a regular opioid, start with the 10th 24-hour dose for breathlessness or cough, and as I've already said, you may need higher than usual doses to manage the symptoms. Think about converting to a twice daily or sustained relief preparation or using a syringe driver. This would in addition reduce the number of times the nurse has to contact with the patient. And we're mindful now that our intention is to relieve distress, not to shorten life or prematurely end life. But we must not withhold opioids because we have an inappropriate fear that they may cause respiratory depression. These patients have a high respiratory drive, and we need to manage their anxiety and their distress and their dyspnea as best we can. And finally, terminal agitation or delirium. Think the reversible. Think about a full bladder. Think about a full bowel, constipation. Think about infection, which may be treatable with a single, may help with symptoms, possibly with a single stat dose of antibiotic. Think about the environment. Is there anything we can do to actually make it calmer, more peaceful? Less interventions, and think about pain. Pain is a potent cause of terminal agitation. Can we reposition the patient? Do they need some analgesics? Lorazepam, midazolam, the benzodiazepines can be very effective in terminal agitation. Haloperidol if there's element of delirium, and levomepromazine. This is not going to be straightforward managing this, and it may be a matter of using what you have available. If you have any questions or concerns, or you're not quite sure what to do, please do not hesitate to call the Hospice 24-hour advice line. And here are the numbers: 01823 333 822 or 01935 709 480. There will be an answer 24 hours a day. If they're not immediately able to answer, you can leave a message and you will be called back. We've produced some further presentations, one being managing key symptoms in patients who are unwell with COVID-19, and the other one is about treatment escalation planning conversations. And these will both be available on the St Margaret's Hospice and the Somerset GP Education Trust websites. Thank you for your time.